Welcome to the Equine Vet Connect Podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect Podcast here at Countryside Equine Hospital. Dr. Caitlyn's back with us today. Great topic.
Yeah.
I think it's coming up more and more. Definitely something we discuss a lot, something we're concerned about every day. And really and truly, I think this is something that every one of our listeners needs to be concerned about.
Yes.
More than just from your animal, but just life in general.
Mm-hmm. It affects us too.
Yes.
Yep.
So we're going to talk about antibiotic resistance today.
Yes, we are.
It's kind of a cool topic.
Yeah.
So people, one of the things I found interesting is, do you know the history behind the first antibiotic?
Yes.
Yeah?
Penicillin.
Penicillin.
Yep. It's, now that you ask me, I'm going to forget all of it, but I am familiar, yes.
It was actually a German invention. Mm-hmm. And they smuggled the spores that grew penicillin out of Germany. The scientists that figured this out actually had those spores covering his jacket, his suit jacket.
Oh.
And they flew him out, and he escaped the country with only the clothes on his back. The penicillium spores were actually in his jacket.
See, I didn't know all of this.
Yes.
This is why you needed to tell the story, because you know a lot more than I do.
Yes.
Yeah.
And so they got him out of Germany, then smuggled him out of Europe to the U.S. Mm-hmm. And he brought these spores that he'd been researching to the U.S. And this was the birth of penicillin. Mm-hmm. Pretty cool history.
Yeah, it is.
It's recent.
Yeah. Antibiotics are not, in the grand scheme of things, as far as Eastern medicine and everything, they're very new.
Very.
Yeah.
And the downside is bacteria have been around forever.
Oh, yeah.
And these guys have been living and thriving, doing well forever.
Yeah.
And
literally since the dawn of time.
Yes.
Yeah. When you look for, when people look for, or scientists look for signs of life on other planets, they're looking for bacteria.
Yes.
And those teeny tiny little organisms that are simple, but they evolve and they change to adapt to their environment and survive. And they've survived for millions of years doing this.
They adapt incredibly rapidly, incredibly well. But you're dealing with something that's got a generation life cycle of 24 hours.
Right.
These things, they learn.
Yes.
These little bitty guys, they learn. Because if you think about it, you can find bacteria in Antarctica where it's
in
sub-zero.
the ice caps. Yeah.
You can find them in the little hot pots out in Yellowstone.
That's part of the way that they date when they do the ice sampling, the core sampling, is they look at the bacteria that's in there, and that's how they help date things. And they're living everywhere.
Yes, they are everywhere. They learn how to adapt, which is cool. Mm-hmm. But downside, since we invented antibiotics, as soon as we came up with a way to fight them, they started fighting back.
Correct.
And so antibiotic resistance is real.
It is. It is. Absolutely.
Very real.
I remember I got excited when we decided we were going to talk about this because, A, I'm a nerd, but also I remember this has stayed with me since undergrad. I was in my microbiome class, and one of the first days in lecture, they posted this video, or they started playing this video, and it's a giant agar gel plate, essentially, which is how we plate bacteria and things. And they did on each end, that was no antibiotic. And then there was each section, they would increase the concentration of the antibiotic tenfold. And so they did a time lapse of it. And so they plated this bacteria on each end, and you can physically watch the bacteria. They grow till they get to the next segment, and then they pause. And then you can see a couple offshoots that start to grow because they've made changes and they've adapted. And then they reproduce, and it spreads till they get to the next one. And then they pause, and the same thing. And it is so interesting because you can physically see it, because like you said, these things are reproducing, every 24 hours. And so they, you could physically see them adapt and overcome each concentration of antibiotics. And then they went through and they mapped and basically figured out, how many different strains there now were and all these things. Like, we'll have to link it. It's really interesting.
That's really cool.
Yeah, and it's stayed with me ever since. Like, it's embedded in my brain, and I will not forget it because it's real. Like, you can see it in real time happening, and that's just with one antibiotic at different concentrations. That's not even introducing other antibiotics that they can then adapt to. So it's cool.
It's really interesting. It's really cool. I'm like you. I'm a nerd, so
Yeah.
The whole microbiology thing was pretty fascinating to me.
It is.
And that's, a lot of what we're dealing with, I'd probably say 50% of the cases that we're dealing with in vet med are going to involve some type of an antibiotic. Mm-hmm. This is a commonly used thing. And our generation, antibiotics have always been around. We've always been developing new ones. We're always like, oh, don't worry about it. We got another antibiotic. But if you look, the number of antibiotics that are coming on the market now versus what, we started out with penicillin. Mm-hmm. That one's rocking on for a long time. And then we started developing the macrolides. We started developing the aminoglycosides, the cephalosporins. Mm-hmm. I mean, we were just cranking new antibiotics. If you look, that's slowing down because we're getting less and less ways to develop these antibiotics. I mean, we're still looking we're always looking for new ones, but scientists are having to work harder and harder to come up with new ways to kill these guys.
Yeah, there's only so many ways that you can slow them down or kill them without harming the host.
Right.
So you have to, there's a lot of science that goes in it and understanding, the bacteria and the cell cycle and all of those things. But yeah, it's slowing way down. So our options are limited. And in human medicine, you have even more options. But in veterinary medicine, our options are limited even more because we don't have access to, or shouldn't have access to, all of those that we use for human medicine. So
one of the things that we have to really worry about in horses, if you want to talk about a class of medications that can have a profound effect, it's the antibiotic in horses. Mm-hmm. Because you have to be very careful when choosing antibiotics because some of these antibiotics can induce, they can have an antibiotic-induced colitis, which is this very severe diarrhea. We used to call it colitis X, and we found out, no, that was the antibiotic we gave them. Yeah. And basically it can kill off all the bugs in the GI tract that keep this GI tract functioning. Mm-hmm. And so we have to be very careful, especially in equine med, on our antibiotic choices.
Right.
Because some of these, we killed the infection.
But we
just killed the host.
Yeah, because like we talked about bacteria living everywhere. I mean, they are commensals. Like they are in your skin, they are in your gut, they are everywhere. Mm-hmm. There's areas in the body that are sterile that don't have bacteria, but a lot of big sections of the body do have bacteria and they have a function there.
Correct.
They help us, we have a symbiotic relationship with these guys. And so if we kill them off, that's not good. There's been a lot of research in the human realm now about, your gut microbiome and all the things and how it really affects, a lot of things in your physiology. And it's true. But the same is said for horses. And if we kill them off because we are not judicious with our antibiotic choices, we're going to have a bad day.
Yes.
Yeah.
And out of that, we've developed newer techniques, which we'll get into to help overcome the resistance and talk about a little bit, proper selection. Mm-hmm. There's a lot of things that go into how can we get as close as possible, because if an infection is resistant to an antimicrobial, and that's the one we use, we will continue to make a resistant population. Can actually make the population even more resistant because they see it doesn't kill them. They're like, oh, I just got stronger. Right. Yeah. And the only ones it doesn't kill, those have figured out how to survive. So we kill off the ones we can, and then we're left with these superbugs that we can't kill. Correct. And so this is a very important thing to make sure we hit on the correct antibiotic. Yeah. So we've gotten excited. So antibiotic resistance or antimicrobial resistance is the ability for bacteria to fight off or resist being killed or slowed down by our antibiotic of choice. There's lots of different ways that bacteria basically once one bacteria in a population develops this ability or develops these genes, there's lots of different ways that then it can spread to other bacteria. One of those is vertical transmission. So when it,
sexually reproduces and transfers genes, just like, your mom transferred genes to you. But the other one that bacteria do is called horizontal gene transfer, and it's very interesting. There's one way that one bacteria will form what's called a pilus. I never say that right.
Pills.
But yeah. And it's basically like a little hair-like projection that it like shoots out and it pokes into another bacteria, and then they shoot genetic material called a plasmid across like this little highway, and then it gets into the other bacteria and it integrates itself into the DNA, and then that new cell or that new bacteria now has the genes as well. It can do that. There's these really cool things. I'm like seeing all this microbiome stuff in my brain, and it's like a little movie. It's just so cool. There's this thing called a bacteriophage, which is a virus that can infect one bacteria and basically suck up its genetic material. And if it has resistance genes, then it goes and it infects another bacteria and it injects it. Like, that's a whole thing. It's like a sci-fi movie. Mm-hmm. It's crazy. The other one is if a bacteria dies or like explodes or something and there's just genetic material floating around, other bacteria can just like pick it up and just integrate it in. Yeah.
It's like a battlefield pickup.
Yeah.
You lost your weapon? Oh, I'll take your weapon.
Right. Yeah.
You got a better weapon than I do. I'll go fight.
Yeah. And so then they incorporate all of this genetic material and it may have resistance genes, it may not. It's luck of the draw. But they're changing and adapting so quickly. That's how this happens as quickly as it does.
Well, this isn't happening over years. This is happening in days.
Oh yeah.
Like, this is like, as this infection's going, all these things can be happening.
Yeah. And every like nidus of infection is different. So every like bacteria also do this thing called a biofilm, which is where they basically coat themselves in this slime and they make an environment that is suitable for them. But even within that little biofilm, there's different areas. Like, one might have a lower area of oxygen, one might have a higher area of oxygen, one might have, different, it's just little different mini environments within that environment. But that biofilm is different than the biofilm on the horse across the stall. So every infection is different, and they all can have different changes in different genetic material. And it's a whole thing.
It is really cool.
Yeah.
And it is, I think when you're talking about the plasma transfer, that's my favorite. It's like looking over, seeing your buddy like, oh, you're going to need what I got. Here you go.
I'm going to shoot you up.
Have this plasma. Here you go. Have a plasmid.
Yeah. It's crazy.
Yeah.
And I was reading about it, and they're finding a lot of other ways that there's transmissible genetic elements, basically, which is what they're called, that they can transfer them lots of other ways too. And it's just like, they are just living in their own little universe, doing their thing.
Well, and forever we thought the way this worked was we just had the bacteria that survive. Mm-hmm. Well, then they reproduce.
Nope.
But then we found out, like, no, they're teaming up. It's like all bacteria are friends. Mm-hmm. So
yeah,
here, have some of my stuff.
Yeah.
And that's been the cool thing when they start typing out these genomes and actually looking at the DNA sequences and watching these things get passed. I mean, it is, if you're a nerd, this is like right up there. It's
legit. Like, it is. When I say it's like a sci-fi movie, I'm not kidding. Like, if you look up some of the like animations that they've done on this stuff, it's bizarre, but it happens, and it's so real, and it's been happening for millions of years.
Yes. It's so cool.
Yeah.
So our little, we come up with these antimicrobials, and they're like, oh, man, we've been fighting this forever. Like, come on, let's do this.
Yeah.
I mean, they go after it. So, I think the biggest thing when we're looking at this is when we're attacking an infection, we have to always keep in the back of our mind antimicrobial resistance. Mm-hmm. And this is why when people call in, they're like, oh, I just need an antibiotic. I just need this. It's just an antibiotic. It's not just an antibiotic.
Correct.
There's times and a place to use them. And then there's a lot of things that go into which antibiotic we're going to pick.
Yeah.
Knowing what type. So knowing what type of bacterial infection you're dealing with. We do a lot of cytologies here. We're actually looking at them. Are we dealing with cocci? Are we dealing with rods? Mm-hmm. And then the greatest separator of bacteria is gram-negative and gram-positive. Mm-hmm. If you go all the way back to that first biology class you took in grade school, you're looking through the microscope. Are they blue or are they red?
Well, Dan doesn't know.
I don't know. That's what, every time I do a gram stand, it's like, somebody tell me, is this blue or red?
How did you get through histo?
You get really good at cell architecture.
I guess.
Like, you get really good. So when I took histo, that was my freshman year of vet school.
I never thought about that with you being colorblind.
I was terrified they'd find out.
Yeah. You didn't know?
No, I knew I was.
Yeah, but they didn't know?
Well, no, because I thought if they found out, they would kick me out of vet school.
No, they would help you.
Well, I didn't want them to know that.
Oh,
and then
my gosh.
my other thought is if I'm going to go do this, like, color's important.
You're going to have to figure it out.
I got to figure it out.
Yeah.
So, I mean, I memorize, like, I can tell you, you tell me what color a tube is, I can tell you the anticoagulant that's in it.
I mean, yeah.
I memorized them all. It got to histo, I figured out, like, I can't tell, like, when they start talking about the purple versus this, I couldn't tell that, but I can be like, oh, I can see that structure.
That looks like an eosinophil. I can't tell that it's bright
Yes.
pink, but it looks like an eosinophil.
That's an eosinophil. It's all lobulated. I can tell you.
Oh, man.
I can look at the nucleus and give you an idea what kind of cell
That would
it
be
is.
awful. See, but you missed out because histo, some of the most beautiful slides.
You know, maybe I did, maybe I didn't.
Oh, man.
I had a great time.
Okay, anyway.
But yeah, that's how I got through.
Gram positive versus gram negative.
Yeah, we digress. Yeah, gram positive versus gram negative. So, you know, that's our first differentiation. And that's one of the things that, you know, when we get younger vets in, I can't believe I'm like starting to be the old guy now.
Yep.
I always tell them, like, if you've got an infection, because it's, 3 to 5 days to get the culture back.
Yeah.
If you just look at a cytology and you figure out cocci versus rods, then you run a gram stain, gram negative versus gram positive.
Yeah.
You can narrow your choice down a lot.
Yeah.
Because then you don't have to go grab the biggest, baddest guy in the fight.
Right.
You got a bunch of gram negative rods, grab an aminoglycoside.
Yeah.
Maybe you don't need to go to one like a Baytril. Maybe you can do just a gentamicin. Mm-hmm. And
So when we talk about antibiotics, we make different choices because antibiotics come in several different classes, like we've talked about, your aminoglycosides, fluoroquinolones, macrolides, the cephalosporins, all of those things. The next thing is it bactericidal or bacteriostatic? So does it kill the bacteria or does it slow it down? Is it time dependent or concentration dependent? How does it work? Does it work on the ribosome? Does it work on, there's lots of different ways that antibiotics actually work on those bacteria. But then what class of bacteria does it actually, like what's the spectrum is what we call it. So is it broad spectrum? Is it more of a narrow spectrum? Does it work on aerobes or versus anaerobes? Does it work on gram positives, gram negatives? Like all of these things go into it. And so if we know what bacteria we're dealing with or what population of bacteria we're dealing with, then we can look at all of our choices and make a better choice, make a more narrow targeted choice.
And then the other one you deal with too is where's the infection at. Mm-hmm. Certain antibiotics penetrate other places better than others.
Yep.
You can have the right antibiotic, but if it doesn't let you go that structure, then like we know like cephalosporins love the lungs.
Yeah,
they love to go to the lungs.
Yeah.
So that's a great one to use. Mm-hmm. We know like chloramphenicol, for whatever reason, it loves to go into bone.
Yeah.
So that gives us an idea like based on our infection, these are actually all the things that are going through your vet's mind when we go to treat infection. That whole list that Caitlyn just ran down, we're going to go through every one of those. Mm-hmm. Now, I mean, we may just be standing there staring at it for a minute, and you're like, they're just looking at it.
They're just buffering.
Yeah. No, we're going through this mental checklist in our head. Do. What's my initial choice?
Right.
And
then we factor antimicrobial resistance into it, and we say, okay, is this the right choice? Is it going to contribute to a resistance because it may not work? Or do we want to pick a lower tier because we might not need to go for the big guns? We might be able to knock this out with some soap and water and decontamination and then come in with a lower tier antibiotic and proper wound care and all of these things if it's a wound.
Right.
There's a lot of other things that we can do other than just antibiotics to manage these things as well.
Because that's one of the things, like dealing with horses, you have to be very careful, and we try to minimize our use because of the fear of a colitis, and then also we're limited in what we have. So these are very important steps we have to take.
Yeah. When people call in and they're like, oh, well, I just put it on some SMZs, I'm like, oh. And then the other thing is, so the things that go into antibiotic resistance is overuse and misuse of antibiotics.
Yes.
So underdosing antibiotics, so not giving them the proper dose for the size of the animal or for the proper course of treatment, so how long you're treating them, those can both contribute to antibiotic resistance as well, because if you're underdosing, you're essentially, you're exposing that population of bacteria to a lesser degree than they're supposed to see, and so it's not going to kill off everything, and then like you said, you're going to breed more resistant bacteria.
That's why your doctor and your veterinarian both, when we tell you, like, we need you to finish the course,
We mean it.
yes, you're going to look, the horse may look better in 48 hours. That's not when we stop. If we said 7 days, go the 7 days.
Treat past resolution of clinical signs.
Yes. Do not ease up. Do not quit.
Correct.
You have to keep going.
Yeah.
This is one of the biggest things for stopping or trying to minimize the chance of resistant infections.
Yeah.
Which is why I really don't like just handing out antibiotics everywhere, because, again, right dosage, right length of time, right antibiotic.
You want to have butanbanamine on hand or different topicals on hand, for things to happen, sure. But we don't just willy-nilly give out antibiotics anymore, because we can't. I mean, several years ago, like, the veterinary feed directive came out for food animals and changed how we prescribe antibiotics to food-producing species because of this. I mean,
well, you got to remember, this isn't just about animal safety, but this is about yours as well. These bacteria aren't limited to just people or just animals. Bacteria can leave animals and go to people, so we don't need to be
and vice versa.
Right.
Yeah.
We don't need to be creating superbugs in animals that can then infect people.
Because you talk about, like, so hospital-acquired infections like MRSA in people, so multi-drug resistant Staphylococcus aureus is what MRSA stands for. That is a superbug. And when people get it, it's scary because we can't treat it anymore. Because this this bacteria has seen so many antibiotics in a hospital setting and so many disinfectants that it has become multi-drug resistant. And it is a serious thing.
CDC spends a lot of time trying to figure out what to do about these multi-drug resistant strains. And it's not just MRSA anymore.
Yeah.
It's E. coli.
Yeah.
The salmonellas. They're getting good at this.
And that's the other reason, I hate going to a human hospital. I just do. But we always say, a hospital is no place for a healthy horse.
No.
Because it's not. We keep everything clean and we do all these things, but, the longer a horse stays here that doesn't need to be here, or humans stay in a hospital that don't really need to be in a hospital, their chance of picking up a hospital-acquired infection goes up. And so we don't want to do that. The World Health Organization said that antimicrobial resistance is in the top 10 global problems facing public health now. It's real.
Yes.
Yeah.
Well, and it's interesting because if you go look, they've done some work in like third world countries. Their risk of hospital-acquired infection is actually much lower than here in the first world. Because the first world, we've been cranking out these antibiotics and had access to them willy-nilly, been able to do whatever we wanted to do. We've been growing this population of superbugs. Other places that have not been as aggressive with antimicrobial use, having, whether that be from an access standpoint, their risk is much lower because they have not bred these superbugs. And first world, we've done a great job breeding superbugs.
Yeah.
That's what we've done best.
Yeah. And, things that we can do as far as, like I said earlier, about not just reaching for antibiotics, but cleanliness is huge. Like, you decontaminate before you use your antibiotics. Like, you get rid of as much bacteria as you possibly can before you reach for that next step. There's lots of, like, dilution is the solution to pollution, as we always say. Just getting as much out as you possibly can so that you have a smaller population that you then have to work on is helpful too. But yeah, it's serious. I mean, they've said, in the next couple decades, we're going to be very limited on what antibiotics we actually have available to us that still work. And that's scary.
Well, and that's where that kind of leads into our next topic is, how do you make these decisions? The gold standard is now, and I think will continue to be, the culture and sensitivity. We grow these bacteria, we type them. We actually do antibiotic trials to see what they're sensitive to and what they're not. And we get that report back and we know what we're dealing with. And it's been kind of interesting because now with PCR, we're doing this faster.
Yeah.
Because they're able to go in and genetically type these plasmids we talked about. And they're like, we see this gene, it's going to be resistant to these antimicrobials. I actually was looking into, when I was digging into this years ago, we're looking at bringing culture and sensitivity. It's in-house. There's actually a QT-PCR machine that can crank out a lot of this data in as little as 6 hours.
Yeah.
6 hours, we can identify the type, what bacteria it is.
Yeah.
And then also identify likelihood of resistance to certain antibiotics. The gold standard will always be the little disc or the little dilution wells to know, like, all right,
this is where we're at.
Yep, this one killed it. Nope, this one's growing great. We got gentamicin in this well.
Yeah,
it killed the infection. We got stuff. We got Ceftioflex or Ceftiofur in this one. It was happy as a clam and grew well. Don't use that one.
Don't use that one.
So that'll always be the gold standard.
And we may, this is why we always kind of make the caveat. If we do culture something, we may still start them on antibiotic that day one, but we'll say, when we get this culture and sensitivity back, we might have to change course.
Right.
And that's okay. We're still going to make an educated decision on our first choice antibiotic, but based on the culture, we might have to go to something else, but we're going to do that. We're not going to change 3 times because you're just guessing at that point.
Well, I like to say that first one's called, we take a swag at it.
Yeah.
You know what swag stands for? That's a scientific wild ass guess. So we're going to take a swag at this thing. We're going to use all the knowledge we've got. We're going to make the best decision we can. And that first antibiotic we go to, it is a guess.
Oh, man.
But it's like, we like to narrow it down. We put the odds in our favor.
It's a scientific guess.
It's a scientific one. But then we're going to...
We need to make that a bumper sticker.
Swag. Take swag at it. So,
oh, man.
But we're gonna get that culture. We're gonna send it out to the lab. We're gonna get it to grow. They're gonna report back to us. And that's like one of the things we're always looking at. What's the fastest way we can get that back? We pick a lot of our lab choices.
Yeah.
On how fast we can get that result back.
I'm like running back into the clinic with my swab, like, send it.
Can we get this out UPS now?
Can they come right here, right this second, please?
I need to get this lab today.
Yeah. I'm like checking in the office every day. I'm like, has it come in yet? Has it come in yet?
Because that's when you have that, we get a report back, and it's going to tell us what they're resistant to, what they're sensitive to. But then we're going to start. That's when the next step comes in. It's like, okay, where is this infection? What's the best delivery route for this medication? Which one of these? I've got 4 drugs that it's sensitive to. Well, I just don't pick one based on...
Oh, yeah, I didn't even talk about that, like route of administration and will they take it and can we get it and how expensive is it? Oh, yeah, all that.
Yeah, we look through, and then that's when the next round of decisions. Sometimes it comes in, you got a whole bunch of R's, which stands for resistance.
And you're like, oh, crap.
And you got 1 S, and you're like,
well...
this is where we're at.
Yeah.
We got 1 S.
Yeah.
1 sensitive.
Yeah.
So...
That's a multi-drug resistant bacteria.
Right. So getting that culture and sensitivity, again, it goes back. You've heard this on this podcast 100 times, and like if you learn anything from this podcast, 1, the most expensive medication is the one that doesn't work.
Correct.
2, get an accurate diagnosis.
Correct.
Like narrow your target down to where you can hit what you're aiming at, and that's what that culture helps us do.
Yeah. And we're not supposed to use antibiotics as a preventative either.
No.
Unless there's active infection there, you're not supposed to reach for antibiotics. You're not going to look at something and be like, ooh, that looks like it could be kind of scary. Like, if it's not scary, don't touch it.
No, minimize your use.
Yeah.
And that culture and sensitivity is what really helps. And it's kind of interesting when we talk about when you're looking at a lot of these cultures is a lot of the older antibiotics that that have fallen out of favor, that we quit using, and it's been 10 or 15 years since they were mainstream. What we're starting to see now is those older antibiotics that they're resistant to, because we've thrown so many new things at them, they've lost their resistance to some of these older antibiotics.
They're starting to work again.
Yes.
Yeah.
Some of those first generation cephalosporins that we had resistance to, now they're actually working again. Some of the tetracycline, everything was resistant to tetracycline.
Right.
Well, now it's actually coming back and working quite well.
Yeah.
So it's interesting, again, how fast they develop. But that's why that culture and sensitivity is so important, because one that you may not typically reach for, that may be the one that fixes our problem.
Even within the same class, like I've had one that it was resistant to enrofloxacin but susceptible to marbofloxacin. So it's in the same class. But I was like, okay, well, obviously I have to go for the marbo, which is not one that we typically use. But I'm like, okay, well, it works. So.
Yep. And some of the things we do is different techniques of administration allow us to overcome some of this resistance as well.
Yep.
One of them can be just topical use. Like we may okay, we have this problem right here. We may use a topical antibiotic. We may mix that antibiotic with something else like a tricide, because that says, all right, because you can do what's called a biofilm assay now. And if you're doing these biofilms, you can do this biofilm assay. And what that is we can combine that antibiotic with something like a peroxide. We can combine it with a tricide. And that allows us to overcome some of those resistance mechanisms.
Break that biofilm down.
Right.
Yeah.
And so if you're dealing with some of these multi-drug resistance, a lot of times I'll have them do that biofilm assay, because that gives me a clue, like, okay, yeah, we've got a bunch of resistance, but turns out if I'll mix this with peroxide and use it topically, I'll get rid of the infection. Very common in the reproduction world. We're treating uterine infections. So there's different things we can do to actually modify these antibiotics so they would work better.
Yeah. Yeah.
But the only way we're going to know that, culture and sensitivity, biofilm assays, get it to the nerds, let them help us.
Yeah, because it's not just the genes, and there's lots of other mechanisms, physical mechanisms that bacteria use to fight off the antibiotics as well. So they're, like we said, they're made to survive. Like they're resilient little things.
One of my favorite techniques, I love a regional limb perfusion.
Oh, yeah. Yeah.
This is a really cool technique where we, being a foot guy, I use this a lot.
Yeah.
But we end up putting a tourniquet and we inject the antibiotic into the area we need it, into one of the vessels. But we have a tourniquet, depending on where it's at, we'll put a tourniquet above it. Sometimes if the wound's higher up in the leg, we've got it above and below. And we put that systemic dose of, well, sometimes lower. Some of them are full systemic doses. Some of them are a much lower dose. But we put it in there, let this tourniquet stay on for about 20, 30 minutes, and it gives us a very high tissue concentration, exactly where we need it.
Yep.
And that will allow us to overcome some of these resistances as well by really pushing our concentration up.
Without the systemic side effects. So
Correct.
There's, in some classes of antibiotics, they can be really hard on the kidneys. They can be really hard on, as they go through and they get processed by the body, they can wreak some havoc, not just colitis, but, like I said, problems with the kidney, problems with liver, things like that. So if we can avoid those side effects in these stronger hitting antibiotics and just put them right where we need them, that's super helpful.
Right, especially in some of these, they're cost prohibitive. But when you're using 1/10 of the dose, and you're focused on that one area, and I think one way to think about it is when we're evaluating the ability of a bacteria to kill, it's MIC, minimum inhibitory concentration.
Yep.
These numbers don't actually mean anything; it's just example. But if you have, like, let's say you're talking about amikacin, and the report comes back and it's got like a 10 times MIC, we'll kill this. We know when we actually give these drugs systemically, we can actually look up what will our tissue concentration be. and it says amikacin will work at a 10 times MIC. Well, we know if we give it systemically, we may only get 5 times MIC.
Safely. Yeah.
But if we do as a regional M,
we can get 10
we get
all day
100
long.
times
Yeah.
MIC. And so all of a sudden, this one with intermediate sensitivity becomes useful if the right technique is picked.
Correct. Yeah. And it's, I mean, you can, like Dan was saying, there's topical, you can do oral administration, which then we have to look at absorption and bioavailability and all of those things. You can do injectable, whether it's intravenous or intramuscular, depending on the formulation. Like, you know, we look at all of these things and we're adjusting, like we were just talking about metronidazole rectally the other day.
Yes.
You can give metronidazole orally, and it's better absorbed that way, but horses will not eat when you put them on metronidazole. I mean, your appetite just drops completely off, and you have to eat to heal. So we'll give metronidazole per rectum, but we know that it's not absorbed as well. So we have to increase our dose to overcome that and get back to our concentration. So all of these things are going on in our little brains as we're trying to figure out and make a plan. So it's not, you know, we're not just reaching blindly into the back of the truck and pulling out the first thing we're thinking of. There's a lot of thinking that goes into it.
And what's also interesting is the regionality of antibiotics.
Yeah.
Like,
just even like, because I talked about this with you guys when I first started. I was here for my working interview, and I was like, what's your recipe for cellulitis here? Like, what works here? Because what works here and what works an hour and a half, 2 hours up the road in Aiken, totally different.
Oh, yeah. And like, I went from Kentucky. There was antibiotics like you did not give in Kentucky.
Yeah.
Because you were going to get a colitis. That's just what it is.
Yeah.
And I get here, and people are like, oh, we just give this. I'm like, no.
Oh, I can't.
But it works here.
Yeah.
And like I talked to friends of mine in California, they've got an entirely different microbiome out there. Different things work, different things don't.
Yeah.
So regionality plays a big role. So we're making that swag. We're looking at past experiences with this type of a situation, and this allows us for a better choice.
Yeah. But I would definitely say, like, one of the big takeaways from today is going to be, like, if your vet recommends a culture and sensitivity, it is 100% worth the money to do it and allow them to do it, because that's going to give you the most information and allow you to make the best educated decision that you can, and you're going to be able to clear that infection faster, better, get faster healing, and you're also going to have less resistance, hopefully.
You're going to do it cheaper, too, because the cost of a culture and sensitivity is the same cost of switching an antibiotic. So, really, it's a cost-neutral deal.
Yeah.
So, if you're looking at it from a money perspective, it's cost-neutral.
Yeah.
And if we can get that choice wiser, like you all of a sudden you're 3 to 4 antibiotics deep, like we're just throwing crap at the wall hoping it sticks.
And you've also set yourself up in future infections to have a harder time, because now the body and all your gut, like all the bacteria on the skin, all the bacteria in the gut, they have all seen these antibiotics now. So they have also acquired resistance genes and things. And so, you know, every horse is like its own soup of bacteria, and every time you put an antibiotic in there, the whole soup is getting it. And so it's not just the infection that you're treating now, but it's any infection you might treat in the future.
Right.
So.
No, it's critically important. Culture and sensitivity, 100%. If there's anything I want people to get today is
please do it.
Please.
Yeah.
Like, I think it's one of the most important things.
And it's most of the time it's easy. Like, if you're dealing with a wound, we come in, I'm going to swab it first thing. I'm going to set that to the side, and then I'm going to tackle the wound.
Right.
If we're dealing with lungs, we're going to do a transtracheal wash. We're going to get a little sample. We're going to plate it. We're going to send it off for culture. We're going to look at it under the microscope, see what we've got. Like, it's not... Getting that sample most of the time is not that difficult.
No.
So.
No, we do that a lot. And I tell people, I look at some of these respiratory infections, like, I'm going to go do a cytology and a gram stain, and then you may have to come by and pick up an antibiotic later. I'm not going to leave one now because I don't know what I'm dealing with.
Right.
Let me go home. It's going to take, like, by the time I get back, you're delaying treatment by a couple hours. Get back to the clinic. Run this culture or run the cytology and a gram stain, and it's like, okay, I got gram-positive cocci in here. Let me grab a bottle of Exceed. Oh, crap, I got gram-negative rods. I need to grab gentamicin. So I can get that first swag pretty close in just a few hours. Now I'm waiting on my culture to come back, and it's always like that game, like, did I pick right? Did I pick right? Did I pick right? Like,
and then you get your susceptibility back, and you're like, woohoo!
Yes.
I did it. Yeah, throw yourself a little party.
So yeah, doing
nerd party.
Exactly, and like doing things the right way just doesn't take that much longer. It's not that much more expensive, and in the long run, you're gonna win a lot more. You're gonna win a lot more.
Yeah.
And so yeah, again, back to my horse is sick. Let me just throw it on SMZs.
Please don't.
Don't.
We're not saying that just to be, crotchety veterinarians that want to make money off of you. We're saying it because it's critically important, not only for your horse, but also for public health and people. Mm-hmm. Like, antibiotic resistance it's real, and it's getting scarier and scarier every year. Like, it's in small animal medicine too. I mean, it's very real, and it's not going to go away.
We talk about this a lot in derm cases. The hardest thing I run into is when I go look at a derm case and I'm dealing with a nasty, everybody calls it rain rot, but a dermatophytosis. I got this nasty bacterial skin infection, a pyoderma. And I said, all right, let's go through the history. What all have we done? Well, we had some SMZ, so we did that. That didn't work. We had some leftover of this, so we threw this at it. I'm like, one, there should be nothing left over.
Correct.
But we digress.
Yeah.
And so by the time we get there, this has been going on for 3 weeks. We're on antibiotic number 3, and we're losing this game. And you get this culture, and it comes back with some nasty multi-drug resistant staph, and you're like, now I got to combat this. Mm-hmm. When the right choice would have avoided where we're at now, because that's usually the call, right? It wasn't that bad, so I treated with this, and then it just kept getting worse, so I treated with this, and it got worse, so I treated with this, and then by the time we get there, like, it's bad.
Yeah.
Whereas the first phone call, we'd have knocked this out, and we'd have never gotten to
and
this.
not to mention all the topicals and things that people will put on there that don't help, and it's just like, just call us. We can knock this out better, more efficient. Yes. Like, yeah, we just want to help. Yes. Let us help, please.
So, yeah, there's a lot more that goes into antibiotics than just throwing some pills at it.
Yeah. And I think
what I really hope people get.
I would get so many calls when you could still buy penicillin at like a feed store. Oh, I would get so many calls. It's like, well, I gave it 1 shot of penicillin at this dose, and I was like, 10
cc's of penicillin. That was always the thing.
One time. I was like, that is so grossly underdosed. I can't even, like, it makes me twitch. Like, I'm like, you might as well just pour it on them, because just throw it away.
I'd say the penicillin and the SMZ were the two that those get me the most. It's like, just because you have them don't mean you can just throw it at them and hope.
Don't do it.
Hope ain't a plan.
No, hope is not a plan.
Red antibiotic.
Correct.
Because we've got some that we know, like the lungs, man, that is typically a cephalosporin all day long. Yeah. They love to go there. Skin, cephalosporin's not going to get the job done. Mm-mm. Just not going to happen. Mm-mm. So there may be times where we reach for the SMZ, but we've got a really good case for why we did that.
Yeah. It's not, one antibiotic it's not a blanket. It doesn't do everything that all of its family members do.
Yes. So, kind of end everything this way. What are your key takeaways? If people learn anything from this podcast, what do you hope they get out of it?
I would say just because you have it in your at-home pharmacy doesn't mean you need to use it. Culture and sensitivity all the time, every time. And please follow our directions to the letter. Finish the antibiotics. Do it at the right timing. Like, when you tell me you have antibiotics left over from the last time, my eye's going to start twitching. I'm going to get mad because you shouldn't, because that means you didn't follow directions, and I really need you to follow directions in this instance.
I think the only thing I would add would be if your horse won't take the antibiotic in the form we prescribed, let us know.
Yes.
Like if you're like, he won't eat anything in his feed, and if you try to syringe it to him orally, he will kill us all.
Okay.
Cool.
We can work with that.
We'll make another plan.
Yep.
Or if 2 days in, he no longer will take the antibiotic, let us know.
Yeah, don't wait for 3 more days just because it's a Sunday. Call us and tell us, because if you've just done those first 2 days and then you quit for 3 days, that's going to potentially make our antibiotic, when we start it back up again, not work as well. Right. So, we need to know as soon as it happens. Mm-hmm. Yeah.
Yeah, let us know.
Yeah.
So, Well, Dr. Kate, thanks for being here today. To all the people here at Countryside Equine, we're still pretty fired up, loving to do this podcast. April, thanks for filming this. Casey, thanks for editing all this. We got a great team up here. Just everything from the podcast team to the techs and staff that work here. I love our team.
It's a good place to be.
Yes, ma'am. So and most of all, thanks for our listeners out there. Y'all keep this going, and we really enjoy it. And we're going to keep cranking out those episodes. We're going to keep putting more and more out. So, again, if y'all got questions, comments, send them in. Be happy to get to them. We're still working on some of these little short videos. So when people do have questions, we're going to be attaching those where we got little short videos to answer your questions on, when you listen to the podcast, you're like, oh, I wonder about this. We're going to try to get those answered. Bear with us. We still got real jobs, still got to pay the bills around here. So
keep the lights on.
I know. One day maybe we'll be professional podcasters.
I don't know if I'm cut out for all
I
that.
really don't want to do it. I love being a vet. I ain't going to lie to you.
I got to go get my hands dirty. I can't sit here for too long. I get antsy.
I was thinking about the other day. I've been a vet now for 16 years, and I'm just as excited today to go to work as I was the first day.
You beat the statistic, Dan. Good job.
Love it. Love it. Love it. Love it. So, again, thanks everybody for listening. We'll see y'all next week. Take care.